This chart shows the volume of published research articles on neurofeedback from the year 2000 to 2021. In just 20 years, we see an exponential surge in clinical and scientific interest. Most of that literature focuses on classical neurofeedback. This approach typically targets brainwaves in the 8 to 25 Hz range, specifically alpha and beta activity. The underlying mechanism here is operant conditioning. The clinician sets a frequency target, and when the patient's alert, the brain learns to replicate that state. But a newer methodology targets the infra-low frequency, or ILF regime, brainwave activity below 0.1 Hz. This training relies on continuous waveform following instead of discrete rewards. This configuration creates a technical contradiction. Without an explicit reinforcer to signal success, the classical operant conditioning model cannot explain how these neural changes are actually being guided. To investigate this, a recent systematic mixed studies review analyzed 18 well-documented clinical trials of ILF neurofeedback. The review isolates two main lines of inquiry, identifying the specific physiological mechanisms driving these slow brainwave adjustments and evaluating their efficacy across a wide spectrum of psychological and somatic disorders. The resulting data points to a naturalistic model of endogenous neuromodulation, the brain regulating itself. Yet proving this clinical efficacy exposes a core paradox in how modern psychiatric research measures success. This Prisma flow diagram maps the literature selection process. The researchers started with 70 total records, removed duplicates, and applied strict eligibility criteria, specifically requiring clear descriptions of ILF protocols and objective efficacy parameters to isolate the final 18 included studies. These remaining studies were evaluated using the mixed methods appraisal tool to ensure methodological quality, yielding a robust cluster of quantitative, randomized, and controlled clinical designs. Through these studies, a naturalistic model for ILF begins to emerge. Instead of seeking an external reward, the brain attempts to close the gap between its expected internal state and the actual continuous feedback signal it receives from the clinician. This regulatory process heavily engages two major intrinsic control systems, the default mode network and the salience network. We can trace this engagement anatomically. The empirically derived standard electrode placements used in ILF therapies, specifically the T3, T4, and P4 positions, map directly onto the accessible cortical hubs of these exact multimodal association networks. To confirm this anatomical link, a 2020 study by Dobrushina and colleagues examined functional MRI patterns in healthy subjects exposed to ILF training. Following a single session, the scans revealed a significant increase in functional connectivity between key regions of the salience network and the brain's broader sensory processing networks. This neural imaging is corroborated by quantitative EEG and neurovegetative data. Another study observed that a single session increased cortical beta activity, reduced alpha activity, and generated immediate improvements in both heart rate variability and galvanic skin resistance. These combined biomarkers establish an objective baseline. They confirm that ILF training induces measurable changes in whole brain network connectivity and autonomic balance, validating the naturalistic mechanism independent of any placebo effect. With the physiological mechanism established in healthy individuals, the review turns to clinical populations suffering from severe arousal dysregulation. One prominent dataset comes from a multi-center analysis in Germany, which evaluated 196 children diagnosed with ADHD. Following their ILF training regimens, the children logged measurable improvements on continuous attention performance tasks, specifically recording faster reaction times alongside a reduction in both omission and commission errors. The efficacy applies similarly to severe trauma. A separate pilot study tested ILF protocols on a cohort of war refugees diagnosed with complex post-traumatic stress disorder. Compared to a control group, the treated individuals registered significant symptom reductions across multiple standardized psychophysiological metrics, including the Hopkins Symptom Checklist and the WHO-5 Wellbeing Index. Parallel metrics were recorded in patients experiencing severe, unmedicated depression. After completing their ILF sessions, these participants saw their scores on the Beck Depression Inventory improve by 70 to 90%. This subjective mood improvement correlated directly with a distinct neurobiological shift, a recorded decrease in slow theta wave activity across the frontal and central cortical areas, paired with increased emotional resilience. The review also highlights somatic applications, documenting how ILF training successfully normalized electrical deviations and improved pain network connectivity in patients suffering from post-concussion syndrome and fibromyalgia. Looking at these disparate pathologies together reveals a unifying principle. ILF neurofeedback does not suppress specific, isolated symptoms. It facilitates the central nervous system's higher-order ability to self-organize and regulate its global stress responses. Evaluating these clinical successes uncovers a deep methodological problem. There is an inherent incompatibility between how ILF therapy is executed and the rigid structure of traditional double-blind randomized controlled trials. The gold standard for medical evidence is the double-blind RCT. By definition, this design demands a rigidly fixed therapeutic protocol applied uniformly to all subjects, measured against a static, inactive sham control group. ILF therapy relies entirely on real-time hyper-individualization. The clinician operates a dynamic, continuous loop, constantly modifying the inputs based on the patient's immediate physiological responses. During a session, the practitioner must actively hunt across the infra-low spectrum to find that specific patient's optimal response frequency, micro-adjusting the target constantly. Beyond tuning the frequency, the physical electrode placements themselves are frequently shifted, moving from T3 and T4 over to T4 and P4, dictated entirely by the patient's real-time feedback. If you force a clinician to use a fixed protocol to satisfy the requirements of an RCT, you actively prevent them from finding the patient's optimal response frequency, thereby artificially depressing the therapy's actual success rate. A secondary, perhaps more urgent issue arises when establishing the sham control group required for these trials. Exposing a control patient to prolonged randomized sham frequencies below 0.1 Hz is not neutral. As the review authors note, it carries a genuine risk of inducing iatrogenic, or treatment-caused, neurovegetative adverse effects. Because of these physiological and ethical risks, the review recommends abandoning standard sham RCTs in this field. Instead, researchers should utilize active concurrent control designs, as outlined by the Declaration of Helsinki. Under an active control design, the potentially harmful placebo is removed. The dynamic ILF neurofeedback is measured directly against a competing, already scientifically validated treatment. Moving forward, studies must also adhere to specialized frameworks, like the CRED-NF guidelines, which are specifically built to accurately document and standardize the reporting of highly dynamic neurofeedback methodologies. Integrating endogenous neuromodulation into mainstream clinical practice requires evolving our scientific methodologies so they can measure dynamic, individualized therapies without sacrificing empirical rigor.